Yeah, so just for background-wise, I've been a doc for about 22 years coming up, and I've had a specialist interest in men's health for about 12 to 14 years. Half my job is as an NHS GP in Warwick, and the other half is for a company called Manual Voy. We're a large private testosterone clinic. We have about 14,000 patients on testosterone, which makes us the largest in the UK, which also makes you susceptible to a lot of scrutiny. So we have to do things very carefully. Oh, great. Thanks. So my talk today is about menopause, which is obviously not a medical term, but is a very well-established social media and general media term that we use for a drop in testosterone in men, because actually most people in the general population don't know what low testosterone is. And we commonly have an association of testosterone with, I don't know, getting stacked at the gym and having better sex, but that's kind of just what testosterone is to the public. And does it do any more? And actually, it does everything. And if you were going to pick one hormone to test that would give you a best indicator of male health, it's probably testosterone, because it's related to all of these factors. And when we talk about men's health, you've got two aspects, really. Men's health is either the anatomical bits, so testicles, penis, anything that makes you male anatomically, or the things that are affected more in male health, so cardiovascular disease, mental health issues, suicide rates, ED, etc., etc. But the point is testosterone is related to all of it. And as Hugh's already said, and I'll save some time by not reiterating the same, testosterone has massive effects on all parts of our body, including active testosterone, DHT, and of course estradiol, which you need all three. And I think that's one of the common things we see in clinic. People be very worried they've got too much estrogen, they want to get rid of all of the estrogen at all costs, but of course that's a disaster. I did interestingly have one patient who was a professional bodybuilder who had taken, perhaps allegedly, a lot more testosterone than is naturally needed, and he also took a lot of aromatase inhibitors. So he had no estrogen, an awful lot of testosterone, and when he sustained his femoral fracture doing squats, we established that not only was he significantly osteoporotic from his loss of estrogen, but he was almost massively built in the other aspects. So you definitely do need the two. He's not competing anymore. So to give you an idea of prevalence, this is a nightmare, really, because the numbers keep changing, and we have about 900,000 men diagnosed in the UK. But again, as we've discussed, Male Massachusetts Aging Study said we've got about 12% of men over 40. But then again, the T40M study is obviously showing that at symptomatic men, that's 40% of all type 2 diabetics. So that's way more than 900,000 men. And we probably think there's about, 2 to 3 million men in the UK that probably have low testosterone, and that's not even symptomatic. It could be even greater. The big question is, are we seeing more men coming to clinic as a result? I would say from a private perspective, definitely yes. From the NHS, I would say, sadly, probably not. But I'll come into that a little bit why. So part of the reason is, I think, as doctors, we don't really get taught about testosterone very much. Obviously, I was at medical school at about 25, 26 years ago now, but at that point, testosterone was talked about in terms of anatomical development in the fetus, you need it for puberty, and then that's kind of it. And you don't really think about anything else, that's fine. I did what was SHO training then, and that was in, so it was core surgical then, and we didn't really get taught anything in urology. There was nothing about testosterone being important there. And then I moved to GP later, and there was nothing really in that. I did an endocrine block, and the chat was really, really nice about it. And we maybe had 1 or 2 patients that glanced through, but there was no specific training. And there's no really big specific postgrad courses that you can do once you even qualify. So you join things like the BSSM, we can join Endocrine Society, but it's very hard if you have a real interest in just testosterone. Of course, the comparison, the reason why I term this male menopause or menopause versus menopause, is the cultural shift towards menopause has changed. And we now have menopause doctors in our clinic. We have BMS, which is very well established throughout the UK. We have menopause advocates. You have menopause cafes. So our NHS practice has a menopause cafe you can go to. Could you imagine having a low testosterone cafe where you could get all of your mates to go around and you could all talk about your erectile dysfunction. Like, I wouldn't go to that. And so you can see the challenges we face in male health are much more difficult. I guess the other thing we talk about that's difficult in terms of trying to think about testosterone deficiency is that I'm not suggesting every woman has a typical pattern of menopause, but it is more predictable about when menopause is going to occur for the majority of women. Whereas men, obviously you've got primary, you've got secondary, you've got functional. So every guy's testosterone is going to drop at some point over 30, but does it affect a guy at 35 or 75? And we don't really know. I mean, the blue graph is pretty rubbish. It doesn't really work like that. But it's just to give you an illustration that actually the women's one is far more predictable perhaps than the men. If you naturally start to reduce your testosterone production by about 1 to 2% after 30, then you could argue, well, it's only 1 to 2%. And if you're otherwise fit and healthy and you do everything well, then you'll never notice it. And 1 to 2% is small. But if you have lots of other things, or you maybe weren't born with quite enough to start with, then suddenly you could have those symptoms in your late 20s or early 30s. And we do see patients that have that. And these are not patients that have had, I don't know, mumps or orchitis, or have had brain tumours and have really unusual reasons for this, which I would probably not be wanting to treat, and I'd probably turf them to Hughes Clinic. But the functional ones, you can get them at different times in life. As we discussed, symptoms of low T are very simple: sexual, psychological, mental, or physical. And I think one of the things we do see in clinical practice is people assume that even though the correlation between sexual dysfunction and, in particular, free testosterone is very well established, not all guys will suffer with that. And I think we often see that there is a cultural or societal normalization that says, well, if you are in your 40s, well, it's normal not to want to have sex so much anymore because maybe you've been married for like 15 years and your wife hates you, or you've got kids and like your kids stop you sleeping, so you don't get good sleep anymore, and maybe you don't have time to go to the gym like you used to, so self-care goes down. So all those sort of things that do impact on your testosterone are seen or deemed as a normal process just of getting older. So of course you then don't go to the doctor because you think, well, it's just because it's where I should be in this stage of my life. And that's true for at least, 75% of men. But for that quarter-ish, then maybe it is something hormonal that we should be thinking about. And as we discussed before, this is a real problem we see in primary care. And the way I kind of use the analogy is like the game Buckaroo. You know, you get the little donkey and you have to load it up with little bits and eventually the donkey kicks. And it's kind of like that for testosterone. And if you imagine that maybe getting older is one of those things, you stick it on the saddle and then you add another one, and maybe you've got high blood pressure, and maybe you have a little bit too much alcohol, and maybe you decide to just get your fungal nails treated, you add that on as well. And eventually, there's enough tick boxes that the donkey kicks, and then you feel that symptomatic loss of testosterone. I'm just kind of ripping through it because I'm aware time is an issue. But supposing you were really keen as a GP and you thought, right, I want to search for testosterone. This is my symptoms for my patient. Where do I look? And so as GPs, we don't obviously remember anything or everything. So we use things like GP Notebook, patient.co.uk, and you can use these little search sites to try and help you find things for symptoms that you want to check online. Obviously, you don't Google it in front of the patient because it looks like you don't know everything, but we don't want to do that. So GP Notebook, this is the tired all the time algorithm we look for. So 8% of all patients presenting to primary care will have tired all the time symptom. And we know, obviously, that low testosterone is definitely associated with a lack of energy and motivation. And yet, GP Notebook doesn't suggest it. It suggests we should be checking serum calcium before we think about low testosterone in men. I don't know why I'd be thinking that. And in patient.co.uk, I should be thinking about HIV and TB before I test for testosterone. I mean, I work in Warwick. We haven't got any cases of TB I'm aware of. But it's just so bizarre that we don't even include this now. If you do want to test it, the reason I've highlighted this is because it depends what your guidance is around testing. And we have, I hate the phrase, but it is a literal postcode lottery around the UK. Depending where you live will determine the reference range of your lower end of testosterone. And the NHS reference ranges don't necessarily match British Society of Sexual Medicine or Endocrine Society guidance at the minute. And I don't blame the NHS. I think there's a very easy narrative to go, oh, the NHS is failing. It should be supporting testosterone better. But I kind of get it because the NHS is really struggling, and we can't get 2-week waits for cancer through particularly easily, and people are waiting 2 to 3 years for their hip replacements. And then suddenly you've got some smart-ass GP who's going, well, I think we should be checking all people for testosterone now. And suddenly it doesn't have that impact in the same way. So I would love to see reference ranges change, and I would love to see things move, but I also appreciate that maybe in the current environment, we aren't the priority. If you do decide to test it in GP, this is a typical set of results we might get back for a patient. So as we said, I would typically want patients to consider treatment. This is just total, not free, but total testosterone with symptoms less than 12. Unless you had metabolic disease, maybe like type 2 diabetes, as we said, which might push you up to maybe nearly 15 if we consider treatment. But the typical reference range is here, 6.7 to 25. So when I rang Warwick Path Lab, because I said, how did you get this number of 6.7, they said, well, it's based on Coventry. I said, okay, great. So we ran Coventry. We said, how did you get the reference range of 6.7? And they said, because it's always been like that. So great. So that's just the way it is. If you wanted to prescribe it yourself as a GP, you're no better off because this is a specialist-only drug. So we aren't supposed to be prescribing it, as you can see. Anything generally in red, I think we're given by our APC prescribing guidance, is bad. We're not supposed to do it. Anything in black is fine. So I can give people finasteride, chuck that stuff out, even though it's not great. But testosterone, you've got to be really careful. And there's lots and lots of things. But this is shared care, specialist only. So even if you have your diagnosis, technically, we should be referring. Things you can do yourself in terms of testosterone, because there is definitely a lifestyle and functional element to this. And most patients that come to see me will be around 2 years in before they will actually see a doctor about their low testosterone symptoms. And that's because I think men, again, culturally, don't like seeing a doctor, and they'll do anything to avoid having to go to their doctor. So they will Google things, and most of them will try lifestyle measures first. So yeah, we definitely know that exercise helps. We definitely know that weight loss helps. We know that at least, around 6 to 7 hours sleep per night is going to be important, and it does feed back to that kind of cultural narrative thing I said about, these are all things that get affected as you get older anyway. Stress, obviously you want a little bit of stress in your life because it's probably good for you. If you, evolutionary-wise, if you are going to be attacked by a saber-toothed tiger, you want a good stress response. We don't have many of those anymore, but what we do have is the chronic stress of your line manager nagging you each day to complete your prescription list or something, which is not good for your testosterone. One question I get asked a lot is about supplements and what can I do to avoid having to see a doctor? Can I just get something over the counter? I would generally say anything that has the word booster in it, I would avoid. There is very little evidence that any of the over-the-counter supplements can have a long-lasting or significant effect on testosterone. There are one or two out there, things like ashwagandha, which have some tentative amounts of data, but it's pretty poor as a whole. And generally I'd say, look, if you're bad enough that you need to improve your testosterone by taking some sort of medicine, then just take TRT. Don't take something you're buying from Holland & Barrett or some other supplement store. One other misnomer we get is, does sex increase testosterone? Well, it probably does a very, very small amount, maybe for a couple of minutes, but then obviously the other hormones that are released, your oxytocins and your dopamines, your serotonin will cancel all that out, and it's certainly not a way to exercise yourself to better testosterone levels in the long term. We do know, however, that increased sex does reduce your risk of prostate cancer, and in fact, if there's a very nice study a couple of years ago that showed that if you are able to perform sexual activity and ejaculate more than 21 times a month as a minimum, then you can reduce your prostate cancer risk by a third, which is great. So I can produce certificates for people if they wish to take this. Also, interestingly, it didn't say that there was a minimum or maximum amount, really. So the minimum was discovered, not a maximum. So you could keep going and maybe have no risk of prostate cancer. I don't know. So these are your sort of treatment options, and I've listed the kind of NHS versus private. Again, not to disparage or have a go at the NHS, but just to highlight that we are much more limited in what we can offer. Everything around the NHS is going to be any drug that is agreed by whichever APC or deanery you're sitting in. We have long-acting injections, sometimes short-acting injections or topical gels. And in the private setting, we also have the options of other short-acting injectables. We will be starting oral testosterone in January, but how great it will be is we don't know, but we'll be doing some trials on that. And the other thing that we can offer more frequently, which is of concern to some men, are medicines that can help improve your own testosterone. So things like clomiphene or HCG. And these can be concerns for men who may still want fertility. And as Hugh had rightly said, one of the big problems with taking testosterone by itself is it will reduce your fertility. So really, I don't ever want to see a 25-year-old in my clinic unless there's a very clear reason why he has low testosterone. Because if we give him TRT, even TRT and HCG, which is better than TRT alone, you are still going to have a risk that your fertility is not as good if we just didn't give you the stuff. But Clomid and HCG is a viable alternative. The problem with that is that it doesn't always make people feel quite as good as testosterone. It's not as good as the real stuff. And the other thing, of course, is that it's a lot more effort to take HCG and testosterone together, and you're having to sort of double your meds, which isn't always a preferable thing for a lot of patients because they're both injectable. And HCG is expensive. But it probably is worth it. So we've just recently published a paper on the improvement symptomatically for patients who take testosterone replacement therapies, and the evidence actually is that it's a really good drug. And there aren't many other drugs out there that you could say to someone will improve your physical well-being, improve your mental health, improve your sexual function. But in addition to all of that, we're also going to make you live longer, reduce your cardiovascular risk, reduce your risk of diabetes, reduce your risk of osteoporosis, et cetera, et cetera, et cetera. So generally, our feedback from patients is extremely good. And from a private setting, the reason why the company likes us in testosterone so much is because our churn rate, or the rate which patients leave, is so low, because once they start testosterone, they never want to come off it. But then the other question is, why should they come off it? Because obviously it should be a lifelong drug. As we've talked about, testosterone is a very safe drug. And the misnomer is that it's related to prostate cancer or it's related to cardiovascular disease, but we've now got really good evidence it just really doesn't do that. Despite that, patients are really scared of this stuff because I think the media and social media are really bad at portraying testosterone as this gym-going, steroid-abusing drug. And so it gets merged in with the idea of what anabolic steroids are, but of course that's not what we're trying to achieve. We do a lot of telemedicine at Voy now, and we were initially a bit nervous about it because obviously the question is, does it provide a safe environment for you to assess all aspects of your patients? And for 99% of men, the answer seems to be yes. The big advantage of telemedicine or video conferencing is that men can talk about things they wouldn't necessarily feel comfortable talking about, either sitting in a waiting room with other people pointing out, wow, I wonder who else in here has got testicular issues, or they can speak in the privacy of their own car or office. So I've done more consultations with people in their cars in the last year than I've ever done. I can pick out makes of car off their seat now because it's such a common thing. And they all go, oh yeah, and I just snuck out of the office because I thought I'd have a bit of quiet time. And it works for them, and it allows them to talk about those issues they'd be just far too nervous talking about normally. So it's been great. And of course, for those patients where we do need to examine testicles, we can bring them in, we can send you for an ultrasound. So I guess the big question then is, why isn't it diagnosed more? Because we've just spent nearly half an hour talking about how amazing testosterone is. And part of the problem is there's this idea that it's like a relatively new area of medicine, but it's not, obviously. And testosterone was first sort of synthesized and used in the late 1930s. So we've got decades and decades of data. We've got 3-4 really massive trials now that show not only is it safe, but it's entirely effective. But it's the doctor and patient awareness thing. And it goes back to that thing I said at the beginning, where you've got a patient who comes in who doesn't necessarily know what's wrong with them because they feel tired or ratty or unhappy or whatever, and so they get given an antidepressant. Or maybe they check their thyroid. Love checking the thyroid in GP. Everyone gets a freaking thyroid. We don't get many pickups on that for men. Or it's just that the doctor doesn't know. So the doctor doesn't know, patient doesn't know, and we get a very unhappy consultation, and then the time goes on and on until we actually pick them up. And that's the comparison with menopause. So the picture on the left is some of the highlights around menopause education, which we've had in the last 5 to 10 years. There was obviously elements on this morning. They've had the Channel 4 documentary, Davina. There were books. You can buy a book on the menopause diet. Apparently you have to eat a special diet if you have menopause. And what do we have in men? Well, so that's me at the Warwickshire doing a talk on testosterone. I've just noticed the guy on the far right couldn't have even bothered to put a shirt on. He's got a vest there. So he's come straight from the gym, just gone, I might as well, I've got time for my sauna or something. So we have a massive challenge in promoting good awareness around male health. But it is really important because, as I said at the beginning, it is the best indicator, I think, of overall male health. If I could, I would get every guy in the UK, I would just test their testosterone at the age of 30. And when we have your baseline, but we don't have that choice, obviously. I think if we're spending time treating menopause, we should be thinking about testosterone because the idea is this is a journey together. You're with a couple, and there's no point in treating your wife with HRT and then potentially giving her testosterone so that her libido goes up, and then the guy's going, oh, God, I really wish we hadn't done this. So you need both people together for the journey to work. And it's certainly far more common than we first think, and we shouldn't all be falling into this cultural narrative that says this is what life is like in my 40s and beyond. So I think we need to be aware that NHS treatments are limited, but we shouldn't be having a go at the NHS about that. And I guess the big thing is that, yes, not every guy should be on testosterone, and we don't want every guy on testosterone because then it loses the credibility we're trying so hard to build up around it. But if you get the right patient in, it's a life-changing drug, and that makes it the best specialty because they come back and they're eternally grateful. Obviously, the wife hates you, but they're eternally grateful, and it's really rewarding. So thank you very much.